Okay. Good afternoon, everyone. My name is Susana Molina, and it is my pleasure to welcome you to AHPA's webinar on the Outpatient Prospective Payment System and Physician Fee Schedule Proposed Rule for calendar year 2022. Before we begin, a few housekeeping items. We remind you to keep your microphone muted until the end of the webinar. There will be an opportunity at the end to ask any questions, but in the meantime, you may feel free to include those questions in the chat box and we'll address them at the end. AHPA does plan on submitting comments to CMS in many of the policies that we will be discussing today. So if you have any thoughts or recommendations, please feel free to reach out to our team. For those of you that are not familiar with the Adventist Health Policy Association, we are the policy voice of 5 Seventh-day Adventist affiliated health systems, including Advent Health, Adventist Health, Adventist Healthcare, Kettering Health Network, and Loma Linda University. Today, you'll be hearing from AHPA's public policy team, including myself, Cherie Danielson, Marisa Lopez, and Brandon Cook. So what is OPPS and PFS? The Outpatient Prospective Payment System rule sets the reimbursement rate for Medicare outpatient services, including services provided in the ambulatory surgical center setting. The Physician Fee Schedule rule sets the reimbursement rate for services provided by physicians. Both rules are currently in proposed form, so the policies that we discussed today may change when the final rule is released. Those final rules are expected to be published during the fall. And then both rules, the comments are due on September 17th. And again, AHPA will be submitting comments in response to many of the policies that we discussed today. Before we jump into what the specific proposals are, you should know that despite these rules being issued under a new administration, they do not represent a significant shift in policy. Most of the policies proposed are actually a continuation of policies that were adopted during the Trump administration, and they are being proposed with either none or some changes. There are, however, a few exceptions. For example, CMS is proposing to reverse the elimination of the inpatient-only list, which would have resulted in many procedures shifting to the outpatient setting. CMS is also proposing to reverse a policy that was set to add 260 new procedures to the ambulatory surgical setting. The rule also proposes to strengthen the price transparency rule of 2019, another top policy that was finalized during the Trump administration, as well as continuing payment reductions for 340B drugs. The radiation oncology model, which was expected to be either eliminated or delayed, is also being proposed for continuation with some changes. There are areas, though, where we do see an increased focus on. For example, the policies impacting the inpatient-only list and ambulatory surgical centers signal support from the administration for a more gradual shift to the outpatient setting. We also see in these rules an emphasis on the continued expansion of telehealth coverage within Medicare, with more services added for temporary coverage. Based on remarks by the administration when releasing the OPPS rule, we also know that price transparency is a top priority for the Biden administration, and that CMS will not shy away from strengthening existing penalties. The rules also contain many measures designed to mitigate the impact of the COVID-19 pandemic, as we have seen in other rules released this year. And finally, there's a continued emphasis on health equity and how to address it in hospital quality programs. The Biden administration has included a request for information on health equity in almost every single rule released this year. Sherry Danielson and our team will provide more background on this issue and what is CMS specifically seeking comments on.
So this slide is showing the reality that CMS was seeing in the data last spring. There are many factors that have brought racial and ethnic disparities in healthcare to the forefront of the policymakers' thoughts, but one of them is definitely the COVID-19 pandemic. So CMS was looking at these disparate rates of death due to COVID-19 and started asking itself, so how can we make sure that regardless of someone's race or gender or income level, that everyone has as fair and as just of an opportunity to be as healthy as possible? So after they started looking at this data, or at the same time rather, President Biden issued 3 executive orders in pretty rapid succession, and all of them were touching on issues of health equity. The screenshot you see is just one of those, but all of them really ordered the federal government to pursue, quote, a comprehensive approach to advancing equity for all people, including people of color and others who have been historically underserved, marginalized, and adversely affected by persistent poverty and inequality. In response, we are seeing CMS prioritize closing the health equity gap, and they're seeking comments across IPPS, OPPS, and PFS on ways that the agency can enhance their quality programs to monitor and decrease health disparities, and any opportunities that we see as key stakeholders to improve demographic data, including data around race, ethnicity, gender identity, and primary language. This is an area where AHPA plans to comment. So if you have any feedback that we can pass on to CMS on ways that they can improve, and especially ways that they can make the data that they provide to us as providers more actionable, we want to include that in our comments. Please reach out to us.
And now moving on to the OPPS rule. Next slide, please. This slide provides an overview of all the issues that we will be covering in regards to the OPPS rule. Compared to calendar year 2021, OPPS payments are set to increase by approximately $10.76 billion, which is an increase of 2.3%. And for ambulatory surgical centers, the payments compared to calendar year 2021 are set to actually decrease by approximately $20 million. Now for price transparency, as a reminder, this rule, the price transparency rule of 2019, it was released during the Trump administration, and it requires hospitals to provide a list of all their standard charges in a machine-readable format. It also requires hospitals to provide, in a consumer-friendly manner, their standard charges for 300 shoppable services. And then finally, for hospitals to provide their payer-specific negotiated rates for those same 300 shoppable services. The penalty for not complying with this rule is up to $300 a day. After this rule became effective in January of this year, there have been multiple reports showing how the majority of hospitals are out of compliance with the rule. The image that you see on your right is just one example of many that has been shared by the media. These reports, paired with political pressure from Congress, is why CMS has decided to propose increases to the penalties. We also know that price transparency will continue to be a top issue for this administration. As you can see in the quote on your left, current HHS Secretary Xavier Becerra stated, "I have fought anti-competitive practices before and strongly believe healthcare must be enriched for everyone. With today's proposed rule, we're simply showing hospitals with stiffer penalties that concealing the cost of services and procedures will not be tolerated by this administration." In this rule, CMS is proposed to therefore increase the penalties by adopting a sliding penalty scale. Hospitals with fewer than 30 beds will continue to see the same penalty of up to $300 per day. For those hospitals that have more than 30 beds, the penalties will increase by $10 for each additional bed per day. And then the penalties should not exceed a maximum daily amount of $5,500. And now Sherry will provide more details on the policies impacting the inpatient-only list and the ambulatory surgical center list.
Thanks. So last year's rules, both of these rules, we really saw a sharp increase by the outgoing Trump administration to accelerate the movement of procedures into the outpatient setting. And with the change of administration, we're seeing a more cautious approach, although we also want to emphasize for our members that the momentum for moving procedures into the outpatient setting is definitely still there, but you'll see a more strategic approach in these proposals. So as a quick refresher, CMS uses both the IPO and ASC lists to regulate the site of service for various healthcare procedures. Whether a procedure is included or omitted is determined by many factors, including patient safety, quality of care, and cost. If a procedure is on the inpatient-only list, it means that that procedure is only reimbursable if it is performed in the inpatient setting. If a procedure is on the ambulatory surgical center list, the procedure may be performed at an ASC to reduce cost, but it can still be performed in the inpatient setting. In last year's rule, CMS finalized the phased elimination of the IPO list that would have taken place over the course of 3 years. This year, we see CMS proposing to halt that 3-year phased elimination, re-add the 298 services that were removed from the IPO list at the beginning of this year back onto the list, and they would be back on beginning in calendar year 2022. And then also revise the 2 midnight exemption for procedures that were removed from the IPO list on or after January 1st of this year. These services under this proposal would only be exempt from medical review for 2 years instead of indefinitely exempt, which was previously finalized in last year's OPPS rule. Here is the rationale that CMS gave last year through Administrator Verma. They no longer believe that there is a need for the IPO list in order to identify services that require inpatient care. The new administrator is asking us as stakeholders whether CMS should maintain that longer-term objective of eliminating the IPO list. And if so, they want to know how we think they should best do that, or if we think that they should preserve the IPO list, how should they do that in a way that still encourages care that is both high quality but more affordable? In the same spirit of the rule, we see some proposed changes to the ASC covered procedures list. There are 3 major proposals regarding the ASC CPL that we wanted to highlight for you. First, just a quick refresher on what was proposed last year. CMS eliminated a substantial subset of the addition criteria, which allowed them to add 267 surgical or surgery-like procedures to the covered procedures list. And this year, the administration proposes to reinstate the eliminated addition criteria, remove 258 of the 267 procedures that were added last year, and adopt a new stakeholder nomination process for adding surgical procedures to the CPL in the future. Under this proposal, stakeholders like us would be able to formally nominate procedures and provide public comment on which procedures can safely be added to the covered procedures list.
Thank you, Cherie. Now we can move on to the outpatient quality reporting system. Next slide. In this year's proposed rule, CMS proposes to adopt 3 new measures. The first one is a COVID-19 vaccination among healthcare personnel measure. This measure was finalized for inclusion under IPPS, so it is likely that it will be finalized in OQR. The NQF did not support this measure and requested that CMS provide more refinement to its specifications. CMS, however, believes that this measure has gone through adequate testing and is sufficient for use in the CMS quality reporting programs. CMS is also proposing to adopt a breast screening recall rate measure. CMS explains in the proposed rule that this measure could fill a gap in the OQR by monitoring appropriate rates for imaging recalls that are supported by evidence from clinical literature, although it's important to note that there are no clinical guidelines on the appropriate rates of breast imaging in the outpatient setting. CMS does not plan to submit this measure for NQF endorsement. The third measure CMS proposes to adopt is the segment elevation myocardial infarction, ECQM. This will take the place of two other measures, OP2 and OP3, which the chart abstractions for these measures were deemed as very burdensome. This measure was submitted for NQF endorsement in January of 2021 and is currently under review. CMS is proposing that these next two measures will have voluntary reporting by calendar year of 2023. The first one is the cataracts improvement in patients' visual function measure, which was reported voluntarily until 2015, but was excluded due to concerns of this measure being too burdensome. CMS believes that these concerns have been ameliorated and will restart voluntary reporting. The outpatient NASC survey-based measure will begin with voluntary reporting in calendar year of 2023 and is proposed to have mandatory reporting by calendar year of 2024. This slide includes several measures that CMS is proposing to update the ECQM reporting requirements. Some of the proposals that I want to highlight are the exceptions that CMS is proposing for hospitals that only have a few or no patients for an individual measure, or 5 or fewer applicable discharges per quarter. Next slide, please. CMS is also proposing changes to the validation process, including expanding the extraordinary circumstances exemption to ECQMs. Next slide, please. CMS is also seeking input on quality measures, such as a re-specified version of a patient-reported outcome-based performance measure for THA and TKA, which were removed from the IPO list in calendar year of 2020 and 2018. CMS is also looking at what measures could address disparities in health outcomes across race and ethnicity, or assess pain management procedures, which is now the third most common procedure in the ASCs. CMS is also seeking input on measure updates for safe use of opioids, concurrent prescribing ECQM in the IQR and promoting interoperability program, as it plans to submit these measures to the NQF for re-endorsement. Now moving on to the radiation oncology model. This model was developed to test whether site-neutral bundled payments for radiotherapy could reduce Medicare cost. This was delayed during the COVID-19 pandemic, but CMS will not be, they're proposing to not delay this mandatory model any further. What CMS is proposing is to provide participation exclusions for hospitals in a Pennsylvania rural health model and in a chart model. CMS also proposes to modify its low volume opt-out policy to include hospitals that have fewer than 20 episodes of radiotherapy services across all core-based statistical areas selected for participation. It also makes some changes to included cancer types and radiotherapy modalities included in the model. There are a lot of changes made to the RO model. The proposals on this slide are other ways the CMS is proposing to refine the model. If you would like to have more in the weed details on any of these topics, feel free to reach out to the policy team. CMS is also establishing a new Medicare provider type, rural emergency hospitals, and is seeking comments on a range of requirements that should apply to these facilities to be certified to participate in the Medicare program. That wraps up proposals included in the OPPS proposed rule. Now we will move on to this year's PFS proposed rule. We'll be covering several topics that were included in this year's rule. These measures are included on the slide. The first topic that we will cover is in the PFS is the conversion factor update. To give a little context, CMS made some drastic cuts to the conversion factor for calendar year of 2021. This was because CMS made updates to evaluation and management visits for specialty physicians. While some specialty payments ended up going down, others went up, and this left an overall increase in expenditures for CMS. Since the PFS is under a budget neutrality rule, it cannot have significant changes in expenditures without legislation from Congress. Therefore, CMS has to take money from other places to offset the increased cost. The cost came from decreasing the conversion factor by about 10%. The table here shows the largest anticipated changes to the specialties in 2022. And the biggest update is a 10% increase to portable X-ray suppliers, and the biggest cuts were made to diagnostic testing facilities and interventional radiology. If you would like to see how every specialty is proposed to be impacted in 2022, Table 123 of the proposed rule contains this information. After the PFS cuts to the conversion factor was finalized, the COVID-19 pandemic hit. As many providers lost money due to postponing emergency procedures, the federal government did provide a 3.75% increase to the conversion factor to provide relief that was in the Consolidated Appropriations Act. This increase was only for 2021 and is not currently included for 2022. In order to extend this further, Congress would need to make more changes. And we have seen different healthcare trade organizations advocate for providing additional relief cuts for this conversion factor, especially from those physician organizations which are seeing the biggest cuts. We have not yet seen major efforts in Congress to include this in any bills. If anything were to happen, it would likely be at the end of December, as Congress is focusing on the human infrastructure bill. And for calendar year of 2022, CMS is proposing to reduce this conversion factor again to $33.58. And now I'll pass it back off to Susanna.
Thank you, Marissa. Next slide, please. Protecting Access to Medicare Act, also known as PAMA, was passed by Congress in 2015. And that law was what created the AUC program, the Appropriate Use Criteria program. The goal behind this program is to reduce the overutilization of imaging services and ensure that the service rendered are actually clinically appropriate. This slide provides a detailed overview of the AUC program. In summary, what you should know is that the program requires clinicians ordering imaging services to consult a clinical decision support software. That software gives feedback to the clinician on the imaging service and generates a number as a proof that the consultation happened. That number, as part of the AUC requirements, should then be included in the claim of the imaging service in order for the claim to be paid. If that number is not included in the Medicare claim, then the claim is denied and the person furnishing the imaging service does not get reimbursed. This requirement was set to become effective in January 1st of next year, but due to the COVID-19 pandemic, CMS is proposing to delay it further until January 1st of 2023. However, CMS is taking the opportunity to seek comments on the following. As an example, should claims that lack the AUC information or that number generated by the clinical decision support software be returned to the provider for correction and resubmission as opposed to just simply being denied? And also, are there any areas in the AUC program that are not clear and would benefit from further education from CMS? So moving on to telehealth, this slide provides a summary of the telehealth proposals included in the PFS proposed rule. These proposals include extending the temporary coverage of certain telehealth services, implementing requirements passed by Congress last year relating to telemental health services, permanently reimbursing providers for extended virtual check-ins, and making rural emergency hospitals a new provider designation created by Congress, as Marissa mentioned, a telehealth originating site. In the next slides, I will only be focusing on the first two proposals outlined here. It's also important to note that no new telehealth services are being proposed for permanent coverage. In 2020, CMS decided to cover on a temporary basis 135 new telehealth services. These services were included on a newly created list called Category 3, which CMS is using to collect more data on the services before deciding whether to cover them permanently or not. CMS is now proposing to cover these temporary services until at least January of 2023. CMS is also seeking comments on what other service should CMS cover on a temporary basis. And these are just examples of a few of the ones provided in the proposed rule. In December of last year, Congress also included as part of the Consolidated Appropriations Act, a provision eliminating the geographic originating site requirements for the diagnosis and treatment of mental health services. This means that Medicare will cover telehealth services for mental health regardless of where the patient is located. Congress also adopted guardrails within that legislation to ensure that this policy did not result in lower quality care and increased cost to the Medicare program. So Congress is requiring for a face-to-face visit to take place 6 months prior to the telehealth visit, and then for a subsequent face-to-face visit to happen at a time to be determined by AHHS. So they gave the subsequent visit to be, they gave HHS discretion to determine that. They are also required within the legislation for the clinician furnishing the face-to-face visit to be the same clinician offering the telehealth service. Now, please note that these guardrails only apply to mental health services. They do not apply to visits related to substance use disorders. In this rule, CMS is proposing to require that face-to-face visit to happen at least 6 months after the telehealth visit. They're seeking comments on whether they should adopt a shorter or longer interval, and whether for the sake of complying with the CAA, they should count clinicians within the same practice as the same clinician. Remember that the Consolidated Appropriations Act made this a requirement, but CMS is trying to make this more feasible by counting all clinicians within a practice as one. CMS is also proposing to allow the use of audio-only communications technology for mental health services. However, they're proposing to cover this only if certain guardrails are met. So first, the clinician has to have the capacity to furnish both audio and video telecommunications. The patient has to prefer to have the audio services, or the patient may not have access to both audio and video. And then third, the clinician has to attest that the patient is receiving the telehealth visit from their home. So these 3 items have to be checked in order for the audio-only visit to be covered by Medicare. CMS is also proposing to adopt a modifier to distinguish audio-only services from audio and video services. And they're seeking comments on whether they should require additional documentations to support the clinical appropriateness of audio-only services, and whether they should exclude higher level services such as level 4 or level 5 E&M visits. Even though there are no proposals in the rule related to meeting the direct supervision requirements via telehealth, CMS is seeking comments on this issue. They're asking, should direct supervision be allowed to be met via telehealth permanently? Is it safe to do so? Or should it only be allowed for a subset of services? They're also asking, if made permanently, should they adopt a modifier to distinguish when direct supervision was provided via telehealth as opposed to face-to-face? And all comments are welcome on this request for information. So what's next with telehealth? We do expect a limited expansion based on service line. We saw that with the way Congress expanded telehealth coverage only for mental health. We also see efforts focusing on collecting data to assess the appropriateness of the telehealth services. We see that within the creation of the category 3rd list. We also expect the development of more guardrails, similar to the ones that we saw for mental health services. Policymakers will largely be focusing on assessing program integrity and ensuring that any coverage expansion does not result in increased costs to the Medicare program. We also expect potential telehealth waivers to be included within CMMI models. And because policy at the federal level advances at a much slower pace than at the state level, we do expect more movement at the state front when it comes to expansion of telehealth coverage.
Looking at the Quality Payment Program, the QPP, the Quality Payment Program is used by CMS to advance the quality of care provided to patients. The QPP has 2 participant tracks, MIPS and advanced APMs. In the 2022 proposed rule, CMS is really focusing the majority of the proposals that we'll see on the MIPS value pathways, or MVPs, which were finalized under the Trump administration. Each MVP contains quality and cost measures, as well as improvement activities and promoting interoperability requirements. And the goal of the MVPs is really to improve value, reduce burden, help patients make informed decisions when they're trying to select a clinician, as well as facilitating clinicians' movement into alternative payment models. Within MIPS, payment adjustments are made for eligible clinicians based on their performance in 4 categories. That's quality, cost, improvement activities, and promoting interoperability. Beginning in performance year 2022, CMS proposes to change the weights of the quality and cost domains to be equal to 30% each. And this is something that's required by statute, so we knew that this was coming. So again, really CMS reiterates that they're just focusing on MVPs for the most part. Now, the guiding principles for the MVPs that were finalized in last year's PFS rule, those are not changing. CMS will not be introducing limits within each MVP on which specialties can participate, which was something that we heard some discussion about last regulatory season. But instead, CMS proposes to adopt 7 optional MVPs that would begin in 2023. And they're stated on the slide there. An MVP participant would need to register for any of these desired optional MVPs between April 1st and November 30th, of the performance year. And after that, no changes are allowed. CMS also proposes to phase in the requirement to report the MIPS APM performance pathway measure set over the course of 2022 and 2023, increase the performance threshold from 60 to 75 points, and adopt an exceptional performance threshold of 89 points. CMS also proposes to freeze payment year 2023's quality information standard at the 30th percentile of the MIPS quality performance category score. And this would increase to the 40th percentile by performance year 2040, and also expand the definition of what a MIPS eligible clinician is to include both clinical social workers and certified nurse midwives. We have an opportunity to engage with CMS here. CMS is specifically asking provider stakeholders when they should mandate MVP participation for all MIPS participants. They're also welcoming feedback on any of the other proposals that we just went over.
Okay, taking a look at the Medicare Shared Savings Program. We'll start with a quick overview. This is a voluntary alternative payment model that gives providers the opportunity to create an ACO. The MSSP requires ACOs to engage beneficiaries and report internally on quality and cost metrics. Participants can select different participation tracks, each with a varying level of risk or reward. If you want more information over the participation tracks, please feel free to email us. So looking at some of the proposed changes, CMS is looking at extending the web interface as a collection type for performance year of 2022 and 23. They are also looking at freezing the performance year 23 quality performance standard at the 30th percentile of MIPS quality performance category score. And then they are looking at increasing this to the 40th percentile beginning in performance year of 2024. Additionally, CMS is looking at ways to incentivize the early adoption of eCQMs or MIPS CQMs. And what they would do here is if ACO elects to report all 3 of the eCQMs, as long as they meet the 30th percentile on one of the performance benchmarks, they will have met the quality performance standard. So looking at the quality reporting transition, I know this graph can be kind of busy, but where I want to draw your focus is on the ACO quality performance requirements. ACOs can elect to follow 2 pathways, either the 10 measures within the CMS web interface, or they can report the 3 eCQMs, and this would be through 2022. Beginning in performance year 2023, the ACOs that elected to submit the 10 measures must then submit the additional 3 eCQMs. In performance year 2024, CMS is planning to sunset the web interface, and the following eCQMs would be required for reporting. Now, looking at the ACO quality performance standard, just to reiterate, this will be at the 30th percentile until 2023, and then CMS is looking at raising that threshold to the 40th percentile beginning in performance year of 2024. So this is showing us the proposed performance pathway measure sets. Where I want to draw your attention is to the middle with the management of chronic conditions and treatment of mental health. This is where we see the eCQM collection type. And it is important to mention again that the web interface reporting can be done for 2023 and 2022 and 2023 performance years only. Looking at additional proposals, CMS is looking for ways to streamline the MSSP program. They're looking at reducing the frequency and circumstances for certain submissions to CMS. ACOs will only need to submit sample ACO participant agreements during the application process if requested by CMS. And CMS proposes to remove requirements to submit an executed ACO participant agreement for each ACO at the initial application and renewal. Additionally, they're looking at simplifying the application process by revising requirements for disclosure of prior participation in the MSSP program. And they're updating the extreme and uncontrollable circumstances for performance year 2023 to align with the performance standard freeze. The next program is the OUD treatment service. This came from the Support Act, which called for a new Part B benefit category for OUD treatment services furnished by opioid treatment programs, or OTPs. The rule established a methodology for determining bundle payments for episode care. It created codes for payments for weekly episodes of care that included prescription drugs and non-drug episodes of care, as well as add-on codes for intake and periodic assessment for take-home dosages of prescription drugs. So before diving into the proposed changes, I want to talk about the 2020 PFS final rule that permitted the use of 2-way interactive audio and video tech for counseling and therapy services in a weekly bundle. With the public health emergency brought on by COVID-19, CMS permitted counseling and therapy to be provided via audio-only telephone calls. However, this was temporary. With this PFS rule, CMS is looking at allowing audio-only telephone calls to be permanent. However, they are going to require, or proposing to require, after the public health emergency, if audio-only telephone calls are used, that it is documented in the patient's medical record with the rationale for doing so. Looking at the EPCS for Part D drugs, this was also comes out of the Support Act, in which prescribing a Schedule 2, 3, 4, or 5 controlled substance under Medicare Part D needs to be done electronically. CMS finalized this provision with the effective date of January 1st and a compliance date of January 1st, 2022. However, because of the public health emergency, CMS is now proposing to delay that compliance date until January 1st of 2023. And for long-term care facilities, they're looking at moving that compliance date back until January 1st of 2025. CMS is also looking at putting a compliance threshold in place The compliance threshold would be set at 70%, and this would require prescribing under Part B to be done electronically. For non-compliance with this threshold in 2023, CMS is proposing to limit compliance actions to sending letters to prescribers that are in violation. However, CMS noted that additional compliance action will be considered in future rulemaking.
Now we can move on to evaluation and management visits. CMS is proposing to refine the E&M visit code by allowing splitting or sharing visits performed by both an NPP and a physician. CMS notes that it does not need to split visit billing policy in the office setting because the Incident 2 regulations govern situations where an NPP works with a physician who bills for the visit. CMS also proposes to adopt CPT prefatory language for critical care services. CMS also proposes changes to arrangements made with physicians under the self-referral regulations. This includes arrangements for rental of office space or equipment that meets the needs of other conditions of those regulations. Finally, CMS included an RFI for vaccine administration services. They acknowledge an almost 30% decrease in Medicare payment rates over the last several years for the administration of certain preventative vaccines, such as hepatitis B, pneumonia, and the flu. CMS is also seeking feedback on the $35 add-on payment for those who receive the COVID-19 vaccine at home. This $35 add-on payment was finalized in a CMS interim final rule that was released in the midst of the COVID-19 pandemic. If you have any thoughts about this topic, please feel free to reach out to the policy team. And that wraps up the OPPS and PFS webinar. If you have any questions, feel free to mute your lines or enter your questions in the chat box.
Okay, everyone, thank you again so much for joining this webinar. As Marissa mentioned, please do not hesitate to reach out to us if you have any questions, thoughts, concerns. We will be drafting comments, so please let us know if you're interested in including any thoughts or recommendations. Have a wonderful weekend.